Next slide. Okay, so I put this in here. Okay, so as a disclaimer, but none of you are accredited that I know of about any other agency. But if you were, accredited facilities should check with their accredited body standards for specific hand hygiene program requirements when creating or revising hand hygiene policies and procedures and other relevant documents that could impact their facility's accreditation program. So next slide, Hannah. So I did create some objectives. So as participants, you'll be able to acknowledge key historic moments involving hand hygiene, recognize as a fundamental element that hand hygiene is a fundamental element of infection prevention and control, and identify key components for an effective hand hygiene program, and access relevant and reliable hand hygiene resources. Next slide. So if you've not recognized this gentleman before, this is Ignace Semmelweis. And so he, in 1946, prior to the development and verification and acceptance of the germ theory, he was a Hungarian physician practicing in an obstetric clinic in Vienna and identified an increase in mortality related to childbed fever. In his observations, Semmelweis discovered that medical students being taught in the ward with the higher incidence were coming straight to the ward after having been in the dissecting room with mothers that were deceased from the disease. After implementing hand washing with chlorinated lime solution, he saw a 90% decrease in the mother's mortality rate. So he is known as basically the father of hand washing and hand hygiene. Unfortunately, in his lifetime, he was ridiculed by his colleagues and later mentally broke down, dying while being institutionalized. Can you click it, Hannah? Yeah, there you go. And the next one you should all recognize is Florence Nightingale. And her efforts during the Crimean War between 1854 and 56, are noted for easing the suffering of soldiers and made her a legend. Florence utilized data to improve the care and outcomes of patients. She captured her ideals and concepts in the notes of nursing, of which many reflected on how the environment state influenced the health of the patient. Nightingale's attention to hand hygiene of the patient, the environment, and the hands of those providing care drastically improved soldiers' outcomes. These concepts are still true and are focused among infection prevention and control programs. Click it again. And Joseph Lister improved surgical outcomes with the use of carbolic acid, also known as phenol spray, which is still used today, on the hands, surgical instruments, and surgical wound bandages, establishing surgical antisepsis. In the late 1890s, his antiseptic surgical teaching was improved upon with the cleaning of operative theaters, sterilization of instruments, and the use of sterilized rubber gloves. And his principles are still used today. Next slide. And click it once. And this is just kind of timeline. I just kind of wanted to capture because I think it's interesting, but just to kind of show you how long it took for hand hygiene, hand washing to kind of get embedded in our society. So as already mentioned, we talked about Semmelweis using the chlorinated lime solution to prevent childbed fever, followed by Florence Nightingale's use of hand washing, along with other environmental practices, and Lister's promotion of surgical antiseptic techniques. And between the 1860s and the 1930s, there was a shift from care being provided in the home to public hospitals in cities and urban areas, most of which were affiliated with medical schools and universities. Infection control became an established profession in hospitals during the 1950s in response to a national epidemic of nosocomial Staphylococcus aureus. And this was amid the antibiotic era, which began in the 1940s with the increase in penicillin use that also went through the 1960s. Because of that, in 1963, the Infectious Disease Society of America, also known as IDSA, was formed, and the members from existing groups interested in infectious diseases. The Association for Professionals in Infection Prevention and Control was established in 1972 as a professional society for those working in infection control. The study of efficacy of nosocomial infection control, which is also referred to as CDC, was performed in 1975, which highlighted the importance of surveillance as a component of hospital infection control programs. In CDC, it highlighted key activities among programs which effectively reduced nosocomial infections, including hand hygiene or hand washing. In 1980, the Society of Hospital Epidemiology in America, or SHAE, was founded. It later became the Society for Healthcare Epidemiology in America as care began to shift away from hospitals to actually healthcare facilities. And then in the 1980s, the CDC published guidelines for infection programs, which included the use of hand hygiene to prevent nosocomial infections, but they were not specific to hand hygiene alone. Next slide. So between 1995 and 1996, the CDC developed the Hospital Infection Control Practice Advisory Committee, and later became the Healthcare Infection Control Practice Advisory Committee, or what we lovingly refer to as HICPAC. And they created these guidelines, which included the use of water antiseptics for hand hygiene to combat multi-drug resistant organisms. With the growing use and misuse of antimicrobials, the IDSA and SHAE conjointly released guidelines on preventing antimicrobial resistance in 1997 that also included hand washing and hand hygiene. In 1999, the Institute of Medicine report came out to air as Human Building a Safer Health System. This really spearheaded the quality movement within hospitals particularly, but later extended on to other healthcare facilities. And at the same time, we saw the emergence between 1998 and I guess about 2000, the Global Public-Private Partnership for Hand Washing. This is an advocacy group that was formed in an effort to call attention to the importance of hand washing. It later shortened its name to the Global Hand Washing Partnership. This partnership includes organizations and agencies in over 70 countries and across 5 continents. In 2002, the CDC released the first national guidelines specifically focused on hand hygiene, and they're still referenced today. In 2004, the Joint Commission Accrediting Hospital Organization, or now known as the Joint Commission, released the first set of national patient safety goals, with one of them targeting hand hygiene. And there were other evidence-based practices that began to emerge at that time as well. In 2006, the World Health Organization, also known as WHO, released its advanced draft of hand hygiene guidelines. Bear with me just a second. And then IDSA and SHAE had already released guidelines to prevent antimicrobial resistance. They released additional guidance on how to develop effective antimicrobial stewardship programs, and that's because we were seeing a large amount of antimicrobial resistance. In 2008, the Global Public-Private Partnership, or now the Global Partnership for Hand Washing, declared October 15th Global Hand Washing Day. So WHO publicized their final guidance for hand hygiene 2009. So it took them 3 years to finalize from their advanced draft to the finalized guidance. That same year, the WHO declared May 5th World Hand Hygiene Day as part of their Save Lives, Clean Your Hands campaign. So obviously there's been additional milestones since then, but I thought these were all really important ones, just to kind of show you how long it has taken for hand hygiene, that is a fundamental infection prevention and control tool, to really get established as part of quality in healthcare facilities. And this is not meant to be all-inclusive by any means. These are just quick snapshots. Okay, next slide, Hannah. So what are the key points of hand hygiene? So it is fundamental, as I already mentioned, to infection prevention and control. It should incorporate traditional hand washing with soap and water and the use of alcohol-based hand sanitizer. You may hear the term alcohol-based hand rub. So either they're interchangeable, so whatever your preference is. Mechanical action kills germs when washing with soap and water, not the water temperature. And alcohol-based hand sanitizer is effective against most germs, bacteria, and viruses, provided hands are not visibly soiled. But it is not effective against Clostridium difficile and is not recommended during a norovirus outbreak. Next slide. But what makes a robust hand hygiene program? And so there are some key components that will give you a robust hand hygiene program. The first one is you need to have an established written policy. It should align with the organization's culture of safety with visible leadership support. It should encourage champions at all levels within the organization, from the bottom to the top and the top to the bottom. It incorporates consumer hand hygiene in the program as a safety initiative. Consumer hand hygiene is a great way to prevent Clostridium difficile. And it should provide just-in-time training with practice gaps observed, reflecting a positive patient safety culture. Provides appropriate supplies for policy adherence. Promotes maintenance of healthcare workers' skin integrity. And it should empower its consumers and their families to engage with their care providers in a meaningful way. And I'm going to expand on some of these as we move forward. Next slide. The first one being the written policy. So it should include hand hygiene indications for hand washing and alcohol-based hand sanitizer use. It should include techniques for hand washing with soap and water, as well as for the alcohol-based hand sanitizer use. It should include fingernail hygiene and maintenance, hand hygiene-related dermatitis management, education provision upon hire and annually, and with expectations and frequency for competency assessment. Next slide. So, excuse me. So when you're writing your policy, how do you go about selecting which hand hygiene guidelines to use? So it should be evidence-based. And there are two. There's the Centers for Disease Control and Prevention and World Health Organization. And then you can search the literature as there's lots and lots and lots of studies on hand hygiene and how to create and make sustainable programs. So in addition to these two guidance documents, you could look at the most recent literature. It should recommend following one of these in their entirety. This is a requirement in for those that are accredited by Joint Commission in the National Patient Safety Goal. You have to pick one or the other and follow it in its entirety. And we'll talk more about that in a minute. It should be clear and concise to promote compliance, and it should provide additional resources for staff and consumer education. Next slide. And I know none of you were Joint Commission compliant or accredited, but I wanted to highlight this just as a National Patient Safety Goal, just to show you why they made it a National Patient Safety Goal. And it's still, these three key points are really still prevalent and relevant. But to comply with one or the other, as already mentioned, and to implement a program that follows selected guideline categories 1A, 1B, and 1C. And what those are they're in the order of supporting evidence. So 1A is the strongest, followed by 1B, followed by 1C. So as long as the program includes those categories of evidence-based recommendations, you should have a very good program. It should set goals for improving compliance with hand hygiene guidelines. So even though you're not accredited, it is listed in both of these documents, in the CDC and the WHO guidelines, that you should set goals for improving compliance and monitor it over time. And we'll talk more about that later too. And it should improve compliance with hand hygiene guidelines based on established goals. And just so you know, it did start with hospitals, but Joint Commission provides accreditation to a variety of healthcare facilities, including nursing home and assisted living facilities. And all of them have this National Patient Safety Goal as part of their National Patient Safety Goal, because they have individual goals. Next slide. I threw this in here. I'm probably not going to spend a lot of time, but when I was in the private sector, we were relooking, and we had started a new hand hygiene campaign. Because to be sustainable, you've got to really keep it front and center. So we wanted to start completely over from scratch. And at that time, we began to look at, followed the CDC guidelines. But we thought it was a good opportunity as part of the project to look at, do we still want to follow CDC guidelines, or do we want to look at the WHO? So this is kind of a modified SWOT analysis, I guess, where we just looked at the strengths and the weaknesses of each, the CDC and the WHO. So this is the CDC Hand Hygiene Guidelines Analysis, and this is what we came up with for the strengths. It is based on scientific data. It considers different modes of transmission, so barriers to spore-forming bacteria. It includes surgical antisepsis. It explains the efficacy of the various hand hygiene products. It addresses associated contact dermatitis with hand washing and hand hygiene with alcohol-based hand sanitizer. And it includes resources and information on the Clean Hands Count campaign. But there are some weaknesses. It was last updated in 2002. And I already mentioned to you that if you were to do a literature search, there's tons of literature out there on various aspects of hand hygiene that are recent. I mean, they are plentiful. So it is a little outdated. The technique of covering all surfaces of the hands is not as specific as the WHO guidelines, which I'll show you in a minute. And then the alcohol-based hand rub or sanitizer indications are not very concise. They're a little bit wordy. You'll see what I'm talking about in a minute. And there's observer and selection bias with direct observations. Next slide. So we did the same thing with the WHO. And so these are the strengths and the weaknesses of the WHO guidelines. There are a lot more. It provides hand washing technique as opposed to a time requirement, although they do have a suggested time. Provides alcohol-based hand rub technique recommendations. It outlines the 5 moments for hand hygiene intervention. It expands hand hygiene indications to include hand washing before and after patient contact. Simplifies the language in the guidelines around hand washing and hand antisepsis. It has a better understanding for staff and patients of hand hygiene indications and opportunities. It increases hand washing methods education, and it allows a closer look at OR sinks to reduce splashing, and I'll talk about that as well. It increases leadership involvement in hand hygiene promotion. But it comes with some weaknesses too. So it lacks, I think, the evidence of decreased compliance as compared to the CDC guidelines. So the CDC ranks theirs, you know, the 1A, the 1B, the 1C. It increases time for hand washing procedure. So their time requirement that they have, which is suggested, which is not the focus. The focus is on the technique, but it's 40 to 60 seconds. And then allows for reuse of gloves between patients if processed adequately and unable to track reprocessing of those gloves. Next slide. And this is just to show you the CDC versus the WHO in the language that's there. So it's pretty much verbatim. for the hand hygiene indications, and this is specific for alcohol-based hand rub or sanitizer use. And you can just see how much more cumbersome it is when you're having to read and navigate through that. So the 5 moments of care is pretty straightforward and explicit. Next slide. And this is just some posters that the WHO has. CDC has some as well. You'll see those later on in the presentation. So both support education and visual cues. One of these is, got more information on it. The one on the right is a little bit more straightforward. Next slide. But regardless, there are indications for each on when soap and water should be used versus alcohol-based hand rub or sanitizer. So, if hands are visibly soiled and dirty, the one on the left, soap and water should be used. The one on the right is a contaminated hand after coming out of the patient room, but it doesn't look dirty, but it's also dirty, so that's when you should use the alcohol-based hand rub or sanitizer. Next slide. And I'm not going to go all into the technique, but remember, in your written policy, you want a technique. Technique will be important when we get to the education component, and so this is just a simplified, written out way to look at the alcohol-based hand rub technique. Next slide. And there are some safety considerations. This actually, a poster that's printable. It's actually the Australian Health, but their hand washing that they put out. But I thought it was relevant because there are some safety concerns. And with your consumer population, you'll have them as well. So the safety when you're putting out the alcohol-based hand rub and sanitizer will be important. Next slide. So we're going to shift a little bit to hand washing with soap and water. Next slide. Once again, this is from the Australian Department of Health or their Health Direct. This depicts the steps, and this is equivocal to what's outlined in the Centers for Disease Control. So, but it's a very succinct way to look at it and the technique for doing washing with soap and water. Next slide. And this is another visual depiction of the WHO and their technique. But I want you to see it. So Hannah's going to go to the next slide, and you're going to see a video because this will tell you more about the technique and how it's different. Okay, thanks, Hannah. So go to the next slide. So the one thing I want to say about that, or stay here for a second, is you can download this. There are others that depict the CDC technique as well. So you just have to find a reputable source. Johns Hopkins is a very reputable source. What I want to point out is if you go and observe and you just got to be explicit in your technique and your instructions on how to do hand hygiene, whether it's the CDC or the WHO. Because if you give them the guidance that you're to wash all surfaces of the hand and then go observe, I'm going to tell you they're not going to get the back of the hands and they're not going to get the thumbs. That's why I like this one, because it clearly, if you follow each of those steps, you will get all surfaces of the hands. So just some things to consider when you're looking at what guidance you're going to follow. Right, next slide. Which brings us to education. And so education should be done for staff upon hire annually. It should include a competency assessment, which is a return demonstration, and it should also incorporate just-in-time coaching, so when practice gaps are observed. But it should also encompass education for consumers, families, and visitors, upon admission, periodically, and just-in-time coaching for them as well. Like I already mentioned, there's lots of evidence that patient education or consumer education on hand hygiene, and those that can't maybe follow direction, provide assistance with them, that's a great way to prevent Clostridioides difficile in that population. So it has been shown to be effective in the prevention of C. diff. So, make sure you include your consumers in your program. And if you, and part of the expectation would be, if you can't educate them because they're not able to, then you should at least assist them with the same indications that you would follow. So before and after they eat, before and after they toilet, especially. All right, next slide. And this is just an example of a competency. Don't get hung up too much on all the details in there, but you'll see it includes one for hand washing, one for the alcohol-based hand sanitizer, and general observations. And it does include it for an orientation, annual, or other. And you can invest in, and very cheaply, product aids for helping you assess competency. Luminescent substances with black or UV lights are a great way to help you ensure that they're adequately washing their hands or using the alcohol-based hand sanitizer. Next slide. So what about hand hygiene product selection and considerations? Because products do matter. I'm going to just tell you, products matter a lot. Now, when COVID came, if you'd have said folks would have been making their own alcohol-based hand sanitizer, I would have probably called y'all a liar. I would have never thought we'd have been doing that. I would have never thought we'd have been topping off. You should never top off hand hygiene products. It is not a good practice. It's an easy way for it to get contaminated. But, the pandemic brought in some new things that we had to consider. But I'm going to bring you back to the basics. All right, so one of the considerations should be the compatibility. So you need to consider the compatibility of your products with other hand hygiene products, especially if you're having to use any that have antimicrobial properties. Should have compatibility with the medical exam gloves that you have, and your sterile gloves if you have to use sterile gloves, because certain products can break down gloves, and so you don't want to have that and have a breach with your glove use. You should consider your patient characteristics. Are there any that are high risk where you might need to use a soap maybe that has more antimicrobial properties than just a general soap? What about behavioral, especially when it comes to your alcohol-based hand sanitizer and where you have your locations? Most importantly, it should also include staff preference. If the staff don't like the product, they're less likely to use them. So when you are doing your product selection, you should invite some staff to actually palate it and to look at it and try it out, get some samples, let them see if they like it, because if they don't use it, you're defeating the whole purpose. And it should be skin friendly. So you really want to prevent dermatitis from frequent use. And then fragrance could be an issue. if it's overly fragrant, and it's people who have issues with, say, like asthma, it could create problems. So you want to make sure that it's not too fragrant, and that it's not assaulting. And these are just some examples of dispensers. So one is a touchless, and one is one that you have to actually touch. If you have, these should also be part of routine cleaning. So these should be cleaned routinely when they're emptied. Next slide. So what about dispensation of these products? So there are pump bottles. There can be wall-mounted dispensers, which she already saw, and then there's personal-sized dispensers. So in any of these, like I already mentioned, you don't want to top them off. So once pump bottles become empty, they should be discarded. Wall-mounted dispensers should not be topped off. So when you look at those products, those that have the product that is all enclosed can be put in and then replaced is really what you want. And then with personal size dispensers, and I put this on here for a reason. So with your consumer population, there are some areas, those that have more behavioral issues, where you may not be able to mount it on the wall, but your staff still need, easy use and access, right? So think about, and if you Google a search for these small size dispensers, the term that you're going to see is not personal size. You're going to see pocket size. I changed that to personal size for a reason. So think about it this way. There's a right way to use these and a wrong way to use these. If I've got to reach in my pocket with my dirty hands to get to the alcohol hand sanitizer, that's really defeating the whole purpose, and you shouldn't have to do that. So that's why I label these personal size dispensers, because you want to avoid them being in a pocket. And so there's ways to do that. You can use a lanyard, although a lanyard probably is not going to be the best option probably for your consumers because of some of the behavioral issues, but they are out there. That's the bottom left picture. There are retractable clips. Some work well better than others, but you can see that one on the bottom right. And then there are some that have carboners that you could clip to, maybe your badge, or you could clip it to a belt loop, or you could clip it to a belt. So it allows for ease of access, but it's on the outside of a pocket. And then others, and so that'd be something similar to the one on the right. But there's all kinds out there. Another important consideration is that you're following the manufacturer's instructions for use. Believe it or not, there are some alcohol-based hand sanitizers that will say you can use up to 8 to 10 times in a row, but at that point you need to actually wash your hands with soap and water. So just make sure, and there's a time amount sometimes on some of these. So the size, so like if you're dispensing alcohol-based hand rub, do you have an adequate amount to effectively sanitize your hands? So you just got to look at the manufacturer's instructions for you. What about vendor support? So believe it or not, those that are healthcare industry grade products, DebMed, Perel, Ethelab products usually have quality control, number one, so to assure that you're getting a good quality product. Because remember when everybody was making alcohol-based hand sanitizer during the pandemic, there's a risk of it having some harmful additives in there and the wrong alcohol type. And so you want to get it from a reputable vendor, but those vendors also provide other support. It could be around education. It could be freestanding stands for your dispensers that you could put in communal areas. It could be signage. It could be, with competencies. There's a lot of things. So that's a benefit that you should look into. And then cost. But cost should never be your primary consideration. You should consider it, but it shouldn't be the primary consideration. Next slide. And then what about infrastructure considerations? And there are some. You know, the location, obviously. You need to have dedicated hand washing sinks. To consider when you're looking at which sinks to dedicate for hand washing, in addition to the location, is the dwell depth. So a lot of the newer sinks are coming out that are very shallow. And what that does is it'll allow for splashback. So you want a good depth so that there's not a lot of splashback, because you're going to leave the water running continuously while you're washing your hands. And so if there's splashback and the sinks are dirty, then your hands can get contaminated in the process. What about splash guards? If you have a dedicated sink that's in, say, a medication room or clinical space, and it's very tight and very limited, and you're putting patient care supplies on that counter beside the sink, they can get contaminated from the water. So a splash guard, and I'm here to tell you, you can get very creative with things from Home Depot or Lowe's and making splash guards that are cleanable. You want cleanable splash guards, but it doesn't have to be costly, but it'll protect your patient care supplies. And then faucet aerators. Faucet aerators should be removed, but there's some other considerations there as well. What about your alcohol-based hand sanitizer and stations and dispensers, where they're located? If you have to perform hand hygiene going in and out of patient care rooms, it needs to be readily accessible. I don't see a lot of added advantage in your alcohol-based hand sanitizer being beside your sink. If I can walk to the sink, I can wash with soap and water. So I think a lot has to be looked at the flow and what's going to be the most optimal location to meet the indications that will give the staff the least amount of barriers to perform either hand washing or hand sanitation. What about patient care areas versus your communal areas? So your dining areas, your activity rooms, those places where a lot of people will congregate together, you want to make sure that you have it there as well. And it should be accessible to promote respiratory hygiene and cough etiquette. So I won't put the facility on the spot, but I was very impressed at where, at a facility I just toured, that it was in all the communal areas. It was great, and it was visually, you could see it. There were instructions. There were visible cues to actually use the alcohol-based hand sanitizer. It was really awesome. It was there to support respiratory hygiene and cough etiquette and for visitors. When you're doing construction, your clinical staff need to be involved in where these locations are because of their workflow. So, and that should include either new construction or renovation. There are American Disabilities Act compliance considerations that have to be had, and this is kind of more around, you know, the height requirements from the floor to the point of dispensation. And storage, you know, so obviously these products should be stored in the clean storage area in a cool, dry place. But for the alcohol-based hand sanitizer, there are restrictions on the amount that you can have per smoke compartment. Ideally, they are not mounted over carpet. They have to be a certain amount of inches away from electrical outlets as well. So there's a lot of other considerations around the life safety code compliance. And then there's other safety considerations, and those particularly that I'm referring to are around your behavioral health issues that you have to consider. Next slide. And you should go look. So go out, look at where these locations are. Do you have functioning sinks readily accessible in patient care areas? Do you have the appropriate supplies? So you might have soap, but are there paper towels? Are the paper towels not located on the back of the sink where they can get wet? They should be mounted. Is the sink area clean and dry? Patient care supplies, I mentioned that splash zone. Are they kept away from the splash zone? Maybe that's a time that you might recommend they need a splash guard. What about, are there signs promoting hand hygiene displayed in the area? Are alcohol dispensers readily accessible, and are they filled and working properly? This came from the CDC. All these references are included at the end, so don't fret about if you're interested in looking at these. But this is a great way to go out and look at, does your staff have what they need to perform hand hygiene appropriately? Next slide. And these are some visual cues. I love some of these. So, you know, just to kind of put out there, you can like search some of these. Some of these come from the CDC, some of them came from the WHO. You can just Google and, you know, or use another internet browser. It doesn't matter. It doesn't have to be Google. But just go in and look and go to images, and a lot of these will pop up. There's tons of them out there. Go to the next slide. And there's posters. Here's some more. The one on the left for the patient zone for the CDC, that came from the Clean Hands Count campaign, and it's kind of similar to the 5 moments of care, but I thought it was a good picture. The one on the right is a good depiction of different organisms you might be concerned about that you can pick up on your hands. Next slide. This is one from the CDC and their Clean Hands Saves Lives campaign. Next slide. So, oh, and always talk about auditing and observations. So, when you're developing a campaign, include your frontline staff, make it fun. One of the things that we did was we had contests for our staff to create posters. And those were the posters that we had printed and laminated. And, you know, we gave prizes away. It didn't have to be expensive. It could be a $10 gift card to their favorite sub place. It could be a $10 gift card to Starbucks. You know, a lot of people like Starbucks. Whatever it may be, it could be, you know, lunch one day. But whatever you could do to make it fun, and then highlight and showcase them. We even had song contests where they came up with parodies, which was kind of fun. So just make it fun. Anything that you can highlight hand hygiene and get them involved. So we're going to shift gears to like auditing and observations. It should be performed periodically. And what you want to look for are the number of hand hygiene episodes that are performed out of the number of hand hygiene indications that you observed. If you didn't observe it, you can't say it wasn't performed. So you got to be looking as they go in the room, as they come out, as they're moving from a clean to a dirty procedure, whatever it may be. So if you observe it and they did it when they were supposed to, upon glove removal is really important. And remember, when you're teaching hand hygiene, glove use does not equal hand hygiene. So you got to make sure they're doing that. You should identify your observers. You should have a primary iterator. And what I mean by that is somebody who is very knowledgeable about patients observed and understands the indications and are kind of like your person, which will be your infection prevention nurses, to be your primary iterators. But you should train other disciplines and volunteers to also do some observations, because what's going to happen is as your infection prevention control nurses go out and they do the observations, it's going to have the Hawthorne effect. People are going to know and are going to know that they're looking for hand hygiene. And so when they see them coming, they're going to do it. And so what you want is what's really happening. And so using trained disciplines and volunteers will help you get to what's really happening. Some other ways that you could do some of the observation is maybe through clinical ladder programs or other initiatives. It's not okay just to observe. You need to record the adherence, documenting it over time. And then you need to also provide that feedback. It should include just-in-time coaching. So ideally, if you are seeing that they're getting ready to not do it when they really need to, that's really the optimal time, because you don't want it to lead to a patient safety risk. But if you've observed breach or the break in practice, you want to coach them at that time, but you need to do it in a manner that promotes a culture of safety. So it should be more about the systems and not characteristics within the staff member. So, you know, nobody likes to be told what they're doing wrong, and especially they don't like to be told they're doing it wrong in front of other people. So you need to be sensitive to how you approach that just-in-time coaching. And I believe the WHO and Joint Commission both have resources on scripting on how to have those conversations for just-in-time coaching. But it should also be part of your quality assurance and performance improvement. Have you identified, you know, you have a problem with your compliance? And if so, what are your goals? What are those established goals? Remember back to the National Patient Safety Goals. Have you established goals in which you would expect that your compliance should be? Obviously, if you do a baseline and your compliance is 40 to 60%, which is, believe it or not, where most healthcare facilities will start when they're starting with their hand hygiene campaigns, it will be 40 to 60%. What is the goal? Everybody's goal should be 100%. That's not realistic, though, if you're functioning at 40 to 60%. So you incrementally raise your goal. So maybe, you know, if you start at 40 to 60%, your next goal might be 75 or 80% for a defined period. Then when you get to that and you achieve it, then you bump it up to 100. So it just depends on where you start. So you should have a baseline so that you understand where you are. Next slide. And I just put in here some auditing and observation tools that you can use. There are apps you can download to iPads, iPhones, Androids. There's other automated ways you could do it that are a lot more costly. I would, you know, recommend those. But, you know, a free app on a phone is great. And then you could send the data to yourself. There's ways that you could do that. Or you can use paper. But if you use paper to treat it over time, then you've got to put it somewhere. And an Excel spreadsheet's a good way to do that. But this is one tool. So Hannah, go to the next slide. And this is another tool, and this came from the Oregon Patient Safety Commission, and this was for long-term care facilities. And on the first page on the left, it just kind of gives you where you can document your observations. And then on the back are opportunity categories and some examples. Next slide. And I put in here, so talk about quality assurance and performance improvement and trending it over time. What does that look like? And this is one example. And this was hospital-wide, and it's a percentage, but it's a control chart, right, or what you might call it a run chart. But it establishes kind of goals as well as where they're at and where they started. And you can see, unfortunately for this facility, they had a decline in their hand hygiene over time. But it's a great depiction of your performance. Next slide. And this is another one that's kind of broken down where you can see by discipline and the indication. So the top one is other staff, excluding the physicians and the nursing staff that perform hand hygiene when going from dirty to clean. The great thing about this one, you could organize it from those with the least compliance to the most compliant so that you could prioritize where your interventions need to be. So it kind of helps you narrow down what your scope should be. Next slide. And this is another one. Click it again, I guess. I don't know why it's not showing totally. Yeah, click again. Keep clicking. And this is kind of a dashboard. Something that you click it a couple more times. The picture at the top shows you the overall compliance over time by month for the facility overall, and then broken down to different parts of the facility, but also by indication. So upon entry, moving from a dirty procedure to a clean procedure, after glove use, and upon exit. Next slide. So how do you target the non-compliance? Education, particularly just-in-time coaching, inclusion in your quality assurance and performance improvement process, and identification of hand hygiene failure causes through observations, just-in-time coaching. You know, when you're coaching somebody who had a gap in practice, why? You know, why didn't you do your hand hygiene as you're exiting the patient room? Maybe their hands were full. There's lots of reasons, but what a great way to get their feedback on what they perceive their barriers are. You could also do a frontline staff survey, especially if you're starting out with a new campaign. That's a great time. What do you perceive your barriers are in being able to perform hand washing and hand hygiene with alcohol-based hand sanitizer? And next slide. And I know we're at time, but we're almost done. But this one, this is just a table that came with key causes of hand hygiene non-compliance, or what I prefer to call failures, because I don't think anybody sets out to be non-compliant. There may be a few people, but most people, you know, it's not that they don't want to do the right thing. There usually are systematic reasons and processes or barriers in place on why they were non-compliant. So failure is a better term, but this came from the Joint Commission resources in their Sustaining and Spreading Improvement in Hand Hygiene Compliance, which was published in January 2015, and it came from a 22-month quality improvement project that involved 8 hospitals who voluntarily participated in the project to improve and sustain their hand hygiene compliance. The project started in February of 2008. They didn't start collecting data next year, and they collected data from February 2009 to 2010. Part of that was analyzing what their staff perceived their barriers to be to performing hand hygiene. And so these are some of them. And if you look at them, most of them are systems issues or, you know, barriers to systems. Their hands were full as they came out of the room, ineffective or insufficient education. Their safety culture didn't promote hand hygiene. They were distracted. Why were they distracted? Drill down on that. But this just kind of gives you some ideas of why. The one thing that I'll point out to you is there was variability among these different hospitals. So not every healthcare facility will have the same causes for hand hygiene failure. So that's why it's important for healthcare facilities to look at their own causes for hand hygiene failure. And starting a new program is a great time to do that. Next slide. These are resources. They're all hyperlinked for you. They're here. There's 2 pages of them. Hannah can go to the next page. And then I know we're at time, but we'll stay on if anybody has questions. Thank you, Hannah. And if you have questions later, any of you decide that you want to take on creating a hand hygiene campaign at your facility and you need feedback, we're glad to give you that. But
okay. This is Hannah. Thank you so much for presenting today. It was great. I just got a text from Max because he is monitoring the chat box for us, and he said there were no questions, but one just came in about a copy of the PowerPoint.
Yes, and we'll definitely provide that. And we have recorded this as well. So we'll provide that to Rob McBurney, and he can share it with you guys.
We've got some that was very helpful information as well. So thank you guys. I'm glad y'all enjoyed it. Becky worked super hard on this, and she's great at talking about a robust hand hygiene program.
And I'm sure I didn't touch on everything, but I tried to really pick the highlights. So, and you're welcome. But you guys got a great start in hygiene after being on site this week. So, okay.
Awesome.
Well, if there, go ahead, Hannah.
Oh, I was just going to say, well, if there's no more questions, if you do have more, feel free to email me or Becky, or you can email Rob, and he has our contact information, or your regional infection preventionist. They know how to get a hold of us too. We talk to them a lot. And we will definitely make sure we get Rob all of these trainings and recordings, and we also have all of the references in the PowerPoint as well. So if that's all, thank you so much, Becky, and we can adjourn.
Y'all are welcome, and have a great weekend.
Bye, everybody.